You know, the weirdest thing in the world is trying to fix your hair while you're looking at yourself on this camcorder. It's like I go to do the right side and I'm fluffing the left or pushing it out of the wrong eyeball. It's really weird. It's not like looking in a mirror. Okay, so we're doing cardiac pediatrics. You should have gotten a lot of A&P on the normal heart after it's gone through the pulmonary transition from the fetal circulation, and we're going to try to cover everything that is specific to the pediatrics. I posted a very big PowerPoint, but I decided that was way too big. Some of that information um, you may not ever see again. So I cut that PowerPoint down, and I hope that we get everything that we need out of this PowerPoint. Okay? Alright. Just a pediatric cardiac card. Alright, cardiovascular dysfunction. And we're talking mainly in infants and children. You've already had your adult. Miss Lindsay has gone over it. We'll finish it up on Tuesday morning, and then we'll start this lecture on Tuesday afternoon for the traditional. Of course, you can start whenever you want to. One of the most important things about doing your cardiovascular dysfunction is to be sure and get a good history and physical exam. Not only do you need to get a history and physical on the infant, but you also need a history of mom's labor with this patient, history of how her delivery went, things that may have an effect on what you're looking at with your cardiovascular system. So you know what to look for in cardiovascular functions. You're looking for the color, chest deformities, all of these things. You're still assessing the same thing you would with an adult. You still use the electrocardiogram, you still can use an EKG, and of course we can use cardiac catheterization. One of the main things about our cardiac catheterization is that we can use it for diagnostic or intervention. So we can diagnose cardiac defects that we may not have found earlier on, or we may go in and balloon it and fix it. So we want to be sure that we're looking at those things. They're divided up, the dysfunctions are divided up into two major groups: acquired cardiac disorders and congenital heart disease. The congenital heart disease, of course, occurs in utero. And if we don't fix them, some of the clinical consequences of not being able to repair these defects are that these kids will go into congestive heart failure or hypoxemia, which we'll talk about later in the PowerPoint. There are different things that you have to remember with children rather than adults, is that you have to consider that developmental age and growth. So growth and development has a big part on how you're going to explain this. You know, if it's an infant, of course you're not going to explain it to them, but you're going to explain it to their parents. But if it's a toddler, you're going to have to do some explaining on their level. So you really have to assess what their level they're at and what understanding level they're at, so that you're able to explain procedures to them. On page 845, it's quite a ways away from where this chapter starts, but on page 845 you have prepare the child and family for invasive procedures, which they covered in another chapter somewhere, and then how to provide your post-operative care. So basically they're telling you what you should do with your children and how to prepare them for it. When you go to do the post or the pre-procedural care, it's part of your assessment. You have to make sure, you know, as you're assessing the skin, if they have a severe diaper rash, that would be one reason that you may not be able to provide go ahead and do the cardiac cath. So you probably would like to notify the caregiver that this severe diaper rash, it may be covering up the groin area where you're planning on doing your cardiac cath, and you certainly don't want to introduce, especially severe diaper rash is usually caused from yeast, so you certainly don't want to introduce a fungal infection into the heart. In your post-procedural cares, you want to be sure that if you're having to do suction, that you're making sure that you're giving supplemental oxygen while you're doing suctioning on a child or an infant. You're going to be monitoring for a lot of things post-procedural. Things for like hemorrhage, because that's one of the things that can be acute in children. One of the other things that you're going to be watching for is going to be dysrhythmias, because you're putting the catheter into the heart, and it can cause dysrhythmia. So you want to be sure that you are watching for those things when you're doing a cardiac cath. So most of the time your child's going to be kept just like an adult with their legs straight for a certain period of time after having a venous or arterial catheterization. And you want to encourage that child to take in a lot of fluids and void to get rid of that contrast that they take in. And then, of course, there is on page 823 after cardiac care. So be sure that you look at that box. It's, pressure dressing stays on until the day after and then has to be removed. You want to keep that site clean. They can't soak in the tub. They can take showers. Be sure that you're monitoring, have the parents monitor for fever. No strenuous exercise, but they can attend school. And usually they use Tylenol or ibuprofen for pain. And be sure you keep up for that. So be very vigilant also in your discharge instructions, that you teach that the child may go into possible regression, especially if the younger child may develop, if he's potty trained, he may go back into not being potty trained, or he may be very needy and dependent. Even though it's just, to us, a simple cardiac cath, it's very high risk for infants and toddlers like that. So be sure you prepare the parents for that. You want to be very vigilant about, after any cardiac procedure or surgery, that you're going to watch for the clinical signs of low cardiac output and poor tissue perfusion, because anything dealing with heart are going to cause these things. And some of the symptoms of these clinical issues, or the clinical signs for low cardiac output and poor tissue perfusion, the skin will be pale, you'll have cool extremities, be cyanotic, mottled skin, delayed capillary refill, have thready pulses. And of course, when we're talking thready pulses, we also need to make sure our pulses on our feet are clearly marked, so that we'll be able to recheck the pulses before and after. Oliguria is a bad sign. And of course, always alteration in level of consciousness. So you want to be sure to keep that in mind when you go. And if you're the surgery nurse and you're reporting off to the floor nurse, some of the things that you need to be sure and tell your floor nurse are, what would you like to know? What would I like to know if I was receiving a child out of surgery? Well, I'd certainly want to know what his last pain medication was. I'd like to know how his vital signs had been. I'd like to know, especially the blood pressure. Has it been low? Have you had any issues with blood pressure? Because I'm dealing with the heart. Any type of IV and the IV rate that I've got going, I need to know what that is. And if they've given any particular type of medications in surgery, so that I would know if they've had to give them any type of medication that might be related to his heart. So I would want to know all those things, if I possibly could, from the report nurse. And hopefully the report nurse would actually be able to tell me those things. All right, congenital heart disease. When does it normally occur? Well, when does it normally occur? When is our actual most developmental portion of the pregnancy happens within that first 8 weeks of pregnancy. With congenital heart disease, you're looking at 4 weeks, because remember, we start hearing the heartbeat at 4 weeks, because we don't hear it, but we can actually see it on ultrasound, that the heart actually begins to beat at around 4 weeks. So usually this is at the time that we're seeing congenital heart disease occurring, is in that first 4 weeks of gestation. So do we have maternal risk factors that might affect our uh, babies, that they may have congenital heart disease that we may look for? Yeah, okay. Most of us, the very first thing comes out of our mouth is drugs, and that is very true. Moms who use street drugs, methamphetamines, cocaine, any type of drug can have an effect, especially in that first 4 weeks, have an effect on the congenital heart disease. So we have to, babies that are born of moms who are drug users should really be assessed for congenital heart disease. Now remember, we talked about earlier this semester about high risk OB and about diabetes, and the difference between babies of diabetic, insulin dependent diabetics, or diabetes 1 type, and then diabetes type 2. The difference in those, and the gestational diabetes. And we determined that with type 1 diabetes, there is a really high risk for congenital heart disease to occur, because if that glucose is not in control for a month or so before she conceives, then there's so much sugar and all these different factors that will affect the fetal heart and will cause to have congenital heart disease. So we really need to make sure that we're watching for any kind of cardiac defects with babies of diabetic mothers, especially type 1. All right, let's talk about my favorite subject. I love talking about our fetal circulation. It's, to me, just one of the most amazing things in the world. So I'm going to click over to this little slide that shows you what fetal circulation is. So, where does it come from and where does it go? Well, it starts with oxygen exchange at the placenta. Remember, we talked about how this is the maternal side and this is the fetal side. The fetal side is nice and smooth, and then the maternal side is all kind of looks like chopped liver, because it's attached to the uterus, and oxygen exchange occurs at the capillary level and then comes over into the placenta. So once this occurs, it travels to the fetus through the umbilical vein to the ductus arteriosus, or to the ductus venus. Excuse me, I'm so used to saying ductus arteriosus. So which one of these, find my little arrow, I think it went plumb up to, there we go, plumb up to Egypt. So you can see these are arteries and this is the vein. So our oxygenated blood is going to go up through our umbilical vein. I don't know why my arrow keeps disappearing. Okay, so here we go. You can see very plainly here where it's coming back down and emptying back in and going back through to return the used toxins and get the blood reoxygenated. So it drops off right here. It deposits some oxygenated blood into the liver. That's always a good thing. And then it travels upward through the inferior vena cava. So the inferior vena cava right here, it starts traveling upward to the inferior vena cava. And then it empties into where? What happens to my arrow? It just keeps disappearing. What side of the heart is this? This is the right side of the heart. The right side of the heart pumps blood to where? Normally it pumps blood to the lungs, because the right side of the heart normally has deoxygenated blood in it, doesn't it? But our right side of the heart has our oxygenated blood in it. So it's totally opposite of what it would be after delivery. You see over here you have the normal heart after it delivers. The ductus is closed. The foramen ovale has closed. So we have normal circulation. But here in the fetus, right now, what's happening is that we're getting oxygenated blood in the right side of the heart. And then this blood is going to go up into the aorta, and it's going to bypass the lungs simply because we have the ductus arteriosus here. It's open, and if I could get my arrow to continually show up, I would be happy. Right here is where we're looking at our ductus arteriosus. It's open so that blood will come up in, the oxygenated blood will come up here. Of course, it's going to mix some with the deoxygenated blood, and then it's going to go to the rest of the body, and a little bit of it goes up here to the lungs. But the reason that not very much of it goes up here to the lungs is because the lungs have a very high pressure gradient. This high pressure gradient keeps the blood from going in because the gradient is higher than the pressure of the blood. So, I didn't mean to do that. But this is kind of a better picture. We'll just go with it too. So you see that it's how that's working that way. The umbilical vein has the nice enriched blood, and of course it's going to mix with the vena cava. It also mixes with the inferior vena cava, so it's always a mixture of oxygenated and deoxygenated blood. Remember I talked about how this actually will occur in utero, that this occurs in utero, and the baby's oxygenation, or if you did a pulse ox on this baby, that you would actually be seeing a pulse ox of around 50 or so. So that when a baby's born, it's no wonder it looks blue, because their oxygenation level is only at about 50%. They don't need anything higher because of the fetal circulation. So once it enters into that right atrium, there's going to be a conduit between the two atriums. So where are atriums? Right up here at the top. I swear I can see my arrow up on top of my desk. Isn't that amazing? So not only are we going to have a conduit between the two atriums, it allows blood to flow from the right atrium into the left atrium, and that's usually what? Our foramen ovale. You see that we're getting this blood flow right through there. And it's very rich in oxygen that goes down into the left ventricle and the left atrium, and then from there the left atrium pumps the blood up into the pulmonary, or not pulmonary, but into your aorta, aortic arch. So the ductus, which is right here, is allowing the blood to flow that's supposed to go into the lungs. We're actually causing it to be bypassed. We just allow a little bit of the blood flow to go into the lungs on either side, but this ductus is allowing, because of the pressure gradient of the lung, most of the blood flows through this ductus and allows most of the blood to go to the rest of the body through the descending aorta. So along with the pressure gradients of the lungs and this open ductus, the lungs do not receive the majority of the blood that comes through. And we all know that this doesn't work once we get delivered and we have to breathe air. Doesn't work that way, does it? So what's going to happen if this ductus arteriosus doesn't close at birth? Well, this type of circulation will continue on, and we'll probably hear a murmur in here, where when the heart pumps, the blood will continue, the oxygenated blood, and will mix with the deoxygenated blood, and then we'll have a mix of deoxygenated blood going into of deoxygenated and oxygenated blood going into the body. So is this a good thing or a bad thing? Well, it kind of depends on the heart defect that you have. If you have a heart defect that is cyanotic or obstructed, this little opening right here may be the only thing that's keeping your baby oxygenated. It will allow a mixture of the oxygenated, deoxygenated blood. So there's certain types of defects that this would be a good thing. Most of the time it's not a good thing, but same thing with the patent ductus, or same thing with the ductus arteriosus. If it doesn't close, is it a good thing or a bad thing? And again, it kind of depends on the type of congenital heart defect you've got. So the blood's pumped from the left ventricle into the aorta, goes into the systemic circulation. Of course, some of the blood returns from the upper extremities and the brain to the superior vena cava. Then it goes to the right ventricle and it's pumped into the pulmonary artery. Since the fetus isn't using the lungs at this time because of those pressure gradients, the majority of the blood passes through the ductus and very small amount goes to the lungs. So what is this ductus arteriosus that we keep talking about? It's just a channel that connects the aorta and the pulmonary artery, and it allows most of the blood to go into the systemic. It's made that way, so because we're not using the lungs in the fetus portion, we don't need a lot of blood into the lungs. So our oxygenated blood needs to go to our other systems. If our ductus closes at birth, that's great. But if we had a certain cardiac defect, that would not be great. And we're going to talk about how we might keep that open. So we may or may not hear a systemic murmur with this. So remember that pulmonary resistance is high. Blood bypasses the lungs. Blood has that lower level of oxygenation, which we've already talked about. Especially if they're born and this pulmonary vascular resistance continues to occur, they will have low levels of oxygen. Because if we have pulmonary vascular resistance when they're born, that means we don't have enough surfactant in the lungs for them to actually be able to, for the alveoli to open up. So we're looking at having some vascular resistance in the lungs, which means we don't get good oxygen exchange, which means we're going to have some cyanotic, a cyanotic baby there. In order for us to transition from this fetal circulation that works so wonderful inside the uterus and doesn't work at all outside the uterus, the infant has to establish effective respirations. They have to establish effective respirations to make the transition from fetal circulation to the pulmonary circulation, which is actually what I call, or what you've been hearing, is the intrauterine to extrauterine life, because it is highly different in those particular parts. Okay, let's talk about the classifications of the heart defects. We have 4 different types that used to be known as the cyanotic and acyanotic, which you can see there. And although we all need to learn the 4 classifications, you still hear acyanotic and cyanotic used. It was a little bit simpler then if you just said acyanotic and cyanotic, but they have determined there are certain types of congenital heart defects that need to be changed because they don't really fit into the particular reason why they are that way. On page 825 in your book, there is a chart that says acyanotic and cyanotic, and then under the acyanotic you'll see pulmonary blood, increased pulmonary blood flow and obstruction to blood flow from ventricles. Those are the two main categories that fall under what used to be acyanotic. And then you have a breakdown of what congenital diseases fall in there. So be sure that you look at that. The ASD and the VSD, the PDA, those three are the most common. Atrioventricular canal is not as common, but they all fall under the increased pulmonary blood flow. So all of these defects can cause an increase in the amount of blood that goes into the lungs. And that's not always a good thing. In fact, that's really a bad thing. So why would it be acyanotic? Well, because we're still pumping oxygenated blood into the rest of the system, but we're also having the pulmonary blood is getting some, or the pulmonary system is getting mixed blood. So where they've already oxygenated blood, they're getting this oxygenated, part of this oxygenated blood back into this system, which causes a backup into the lungs and causes them to have pulmonary congestion. The obstructed ones are where they don't get any flow and it causes the blood to back up into the lungs. Then you've got the cyanotic, where the pulmonary blood flow and mixed blood flow are considered in there. Tetralogy of Fallot, tricuspid atresia are one of those. They fall under the cyanotic. Of course, I didn't talk about the acyanotic one, so I can go back and do that for you. Coarctation of aorta, aortic stenosis, and pulmonic stenosis. This coarctation of the aorta, you always need to make sure that you're doing blood pressures in all four extremities. Usually, if you're suspecting a congenital heart defect, if the blood pressure in the upper extremities is a lot higher than what the lower extremities are. I think I said that wrong. Let me think about this. When there's a difference between them, I will get back with that. Blood pressure will be higher in the upper extremities because blood does flow through the upper extremities, but it doesn't flow to the lower extremities. So your blood pressure will be lower in the lower extremities. Then the mixed blood flow, of course, is the transposition of great arteries, truncus arteriosus, and one of my favorites is well, it's not a favorite, but one of the heart disease that fascinates me most is the hypoplastic left heart. When I was learning about all these classifications of defects, they were a lot of these that were considered incompatible with life, and there was nothing we could do about them. And the tetralogy of Fallot, the coarctation of aorta, transposition of the great arteries, and hypoplastic left heart, we just did comfort care for those. Now, babies born with any of these things have a chance to live as long as they get their surgery done on time. All right. We have a defect that results from a connection between the left and right side of the heart, or between the great arteries that allow blood to flow between the left side of the heart. So if you think about this, higher pressure on which side of the heart makes blood flow to the lesser pressure of which side of the heart that would cause increased blood flow to the lungs. Higher pressure on the left side of the heart will make it flow to the right side of the heart. And this, of course, is an increase in the pulmonary blood flow. If we had a right side to left side shunt, where we had higher pressure in the right side that went to the left side, we would have cyanosis, cyanotic disease, where we had decreased pulmonary blood flow. So, regardless of the defect that we have to do interventions that's going to decrease the workload of the heart. Some of the things that we can do to decrease these, decrease the workload of the heart in congenital heart defects, regardless of what kind they are, even in congestive heart failure, are that things like using a preemie nipple instead of a regular nipple. They're a lot softer. They have larger holes in them so that they come out better. We want to be sure, you always want to bond with the infant. You want to make sure that the mother's bonding with the infant. So you want to make sure that we have some passive stimulation. You don't want to go in there and stimulate the baby a lot of times to wake up and engage. You just want to do some passive stimulation, like maybe holding the infant, singing to the infant, letting the infant hear your heartbeat, things like that. You don't want to let these babies cry. If they start to cry, you definitely want to get it stopped. So you really try to not let them cry at all. And yes, I know that sounds like you're going to spoil them, but at that young age, some of them it's just not going to matter. And I'd rather have a spoiled baby than a dead baby, so no crying. The best position to have them in is in an orthostatic position, which is a sitting up position. They shouldn't be on the supine or prone position, especially when they're being fed. They should be kept in an orthostatic position. The mattress should be firm. They should never use a pillow, waterbed, or anything soft like that. So you want to be sure that you're providing all these things. And we also need to provide, like with the bonding, the older kids also need to have, be able to develop to grow in their stage of development. So you want to promote growth and development by encouraging children with heart defects to be able to play with other kids. It's not always, it's not a bad thing. It's a good thing. The only time it's a bad thing is if you're, the person that the child's playing with is deathly, it's got a contagious disease disorder. May have the flu, may have runny, snotty nose, and you don't want your kid to play with them, and that's perfectly fine. I don't even like for my healthy child to play with some child that's sick, but it always happens, and there's nothing you can do about it. But you definitely want to be able to promote that. So to teach your parents it's okay to let your children play with other kids. Alright, let's look at a heart defect. So what are we looking at here? We're looking at how the blood is going to flow down in the patent ductus. So we've got normal left ventricle, normal right ventricle. Looks like our foramen ovale has closed. So right here is our ductus arteriosus. So this would be a patent ductus arteriosus if this is the heart of a child of a baby who has already been born. It's definitely not of a fetus because you don't see the fetal circulation coming in. We have actually the inferior vena cava where blood's coming from, the superior vena cava, and then we have the oxygenated blood going out through the pulmonary vein, and then we have our pulmonary artery that's right in here. This is our aortic arch. So all of this has deoxygenated blood. This is one time you're going to see pulmonary artery carrying deoxygenated blood and the pulmonary vein carrying oxygenated blood. It's already been to the lungs and has been oxygenated, and it's come down here to the right side of the heart, and it's being pumped out into the systemic system. The left side of the heart has a stronger system, has stronger gradient pressure than the right side because they have to pump at a greater distance, so it's got a higher pressure gradient. A patent ductus is going to allow oxygenated blood because this is a higher gradient. You see, this works a little different from fetal circulation. The left side has the higher gradient, so the oxygenated blood is going to mix in with the deoxygenated blood that's going to go back up to the lungs through this pulmonary artery. To get reoxygenated, you're going to have some oxygenated blood going back to get oxygenated that should not be going back in there. So you can see where this is going to be an increase in pulmonary blood flow. It's going to be having more blood pumped back into the right side of the heart that shouldn't be in there, or into the lungs that shouldn't be in there, and it's going to cause the more fluid that builds up into the lungs, the harder the right ventricle has to work, and you're going to see some right-sided failure there. Again, our patent ductus, this is a little bit better picture of it. Shows you how it works a little bit better, because I have arrows in this one. And yay, arrows. Okay. So again, the oxygenated blood. This one shows you a little bit better about how the oxygenated blood that's coming up here through the aortic arch is coming back into the pulmonary artery and therefore going back into the lungs. So you can actually see that that's happening. So we have an increased blood flow to the lungs. What's going to happen is that our left-sided ventricle is going to have to pump harder to get the correct oxygenation to the systems, because some of it's going back into the lungs and not out to the body. And because it has to pump harder, it becomes enlarged. Once these ventricles become enlarged, there's not a whole lot we can do about getting them fixed. So you may, with a patent ductus arteriosus, you may hear a murmur. If you hear a murmur in an infant that's less than 24 hours old, it's usually because this just hasn't closed yet, but it will close as soon as as soon as the baby breathes and the oxygen level of the lungs come up and the oxygen level raises, and there's a whole lot of little chemical things that says close me. So you can actually, with it, first 24 hours, you may hear a murmur off and on, and they're usually benign. They're usually just the transition. But after 24 hours, if you're still hearing a murmur, and the baby stays pink when it's asleep or crying or whatever it is, this is usually your cardiac defect you may be looking for, because this one doesn't have any other symptoms other than maybe a murmur that you may hear. And why is that? Because we're still oxygenating well, and until we have so much increased blood flow to the lungs that we start seeing and the left side of the heart working harder, we'll start seeing congestive heart failure when we start seeing if this isn't fixed. So we need to get this fixed. Once we fix it, we see this. This is how they fix it. So once that ductus closes, why did we fix it? What was wrong? We had oxygenated blood coming into our deoxygenated blood and going to the lungs, right? Increased in pulmonary blood flow. So when we clip it, which it doesn't take, it's just a very simple procedure. This shows you what it really looks like. But once we clip it, we no longer have this deoxygenated blood and oxygenated blood mixing and going back into the lungs. So therefore, the fix is that we have prevented oxygenated blood from going back into the lungs, and that's what we wanted to do. So therefore, that little clip is going to decrease our pulmonary blood flow and get it back to normal, because we don't want to have the increased pulmonary blood flow. We want to stop that oxygenated blood from coming in there. So that's always a great thing. And I'm going to stop with this one and start back, because I'm always afraid I'm going to run out of recording power. So I'm going to stop right here and come back right here.